but it includes all the experts in India who actually deal with TTTS on a regular basis, not just diagnosis, but even management. So we understand that there is a higher rate of TTTS that we see today because of higher rate of ARTs. And when it concerns monochorionic pregnancies, we do have challenges, not only in diagnosis, but also where do we send this patient? How do we counsel this patient? Because we understand that the TTTS can come up at any point in time, and that it can jump the Quintero staging. It did not necessarily follow the Quintero staging. So it does pose a counseling dilemma as to how do we manage this patient. Fortunately, over a period of years, we in India have good doctors who are trained in doing lasers and radiofrequency ablations. And we are fortunate enough that we have few of them who will share their experience today in this webinar. So I'm sure Dr. Aparna is going to make it very interesting. But before we jump to the panel discussion, I would like to have in the inauguration of the Bengal chapter newsletter. Now, traditionally, Bengal has been the only chapter which has consistently produced very good quality newsletters, simply because they have plenty of doctors who are really interested to publish with good machines. So in this newsletter, you are going to find fantastic articles from case reports from Kamal Oswal, Khurshid, Tanaya, Soumya, Tulika. If you go through that, they're very fantastic case reports with excellent images. And that stands out in that journal. But apart from that, I would also want you to go through Dr. Kanchan's article about the Arjikar medical case, a call for justice and a demand for change. He's poured his heart out. That issue is very close to his heart, and he's passionately been following it, raising objection, organizing protests, and he's really poured his heart out in that article. So I urge everyone to go through that article. And I would like to have Dr. Sita Ramurthy, the president of Bengal chapter, to have her point of view on the Bengal newsletter. Over to you, Dr. Sita.
Thank you. Thank you to you, Dr. Mohit, the president of our Society of Fetal Medicine, for formally inaugurating this newsletter. It's been long overdue, and I must thank each one of the Central Committee for giving us this opportunity to release this in this prestigious webinar today. And yes, it's been a mixed bag this time, with all interesting cases coming from stalwarts like, as Dr. Mohit Shah said, from Dr. Kamal Oswal sir, to Tulika Joshi and all the other, contributors. So big thank you to all, and of course a big thank you to Kanchan Mukherjee, who's been part of the newsletters always from its inception, and his write up on the Arjika incident, which has still not seen the light of hope anywhere. We're still struggling to get some justice. We'll see how it goes. But and a special thanks to our mentors, Dr. Kushagrati Ghosh, Dr. Kamal Oswal, and of course our mentor emeritus, Dr. Ashok Khurana sir, for always being there, inspiring us, encouraging us with whatever little we do and whatever we can do. Thank you once again, sir. And a special thanks again to the Dipanjana Datta for coordinating all this and getting out this newsletter. So thank you once again for releasing it today and for this opportunity. Thank you. Thank you.
So can we have the inauguration of the newsletter?
Yeah, can we just have the newsletters displayed there?
Thank you.
Thank you so
Thank
much.
you,
Thank you. Thank you, Dr. Sita. Your Bengal chapter is very proactive in producing very good articles. I love to read
Thank
them. And do thank, I don't see Dr. Kanchan Mukherjee, but he's really poured his heart out
Yes,
in that
sir.
article.
Yeah.
And I really want to personally thank him for his passion in pursuing this topic for quite some time now. I mean, he's persistently been, protesting and organizing those protests, but he's really poured his heart out.
Yeah.
I was really touched after reading that article. Thank you. Thanks to Dr. Kanchan Mukherjee.
Yeah, and thank you to all our executive members as well. Thank
Yeah.
you so much. Thank
So
you.
and now I invite Dr. Aparna Sharma. She has been a dynamic secretary of our association in the last year, where she's proactively done a lot of webinars and conferences. But she is quite instrumental in promoting therapeutic procedures. I would want her expertise here. Oh, Dr. Kanchan has joined. I'm so sorry, Dr. Aparna. I'll just take 1 minute to thank him personally. Kanchanda, your article was fantastic. I've loved it, and I admire your grit and determination in pursuing this matter. But you poured your heart out. I just wanted to congratulate you for it. So
Thank you.
it
Thank you.
deserves a special mention in those academic articles. So I would urge everyone to go and read that newsletter, and do get back to Dr. Kanchan about what you feel about his article. Thank you,
Absolutely.
Kanchanda.
Thank you so much. Thank you. I
Dr.
have heard what you said before. I was in the audience. I was not actually in the faculty lounge.
Oh,
Yes.
okay.
Thank you.
Yeah.
Thank you.
So, Dr. Aparna is a professor in the Fetal Medicine Center at AIMS, and she's been instrumental in introducing multiple procedures for the first time in our country. And she is going to take us to the enigma of twin transfusion, all we need to know. And she's got a fantastic panel of experts which she's going to introduce and begin with. Over to you, Dr. Aparna.
Thank you, Mohit. Good evening, Kurana sir, Mohit sir, and Bimal sir. And thank you for this opportunity to conduct this panel on TTTS on occasion of the World TTTS month, which is December, and the TTTS day is on 7th December. So I would like to begin by introducing my exceptional panelist. We have with us today Professor Vatsala Dadwal, who is the professor and head of maternal-fetal medicine at AIMS, New Delhi. We also have Dr. Chinmay Rath, who is a fetal medicine consultant, and we all know her. Dr. Chinmay, I'm looking forward to your comments and inputs on this particular issue. Dr. Vandana Bansal, who's from Mumbai, and a very well-renowned fetal medicine expert. We also have Dr. Bijay Balakrishnan, who's from Simar, Kochi, and we all have heard him over the years, and special insights are, really requested from you. And of course, we have Dr. Manikandan, who is from Pondicherry, and he does an excellent job on fetal therapy, and I would say he does great justice to whatever topic he talks on. And when I was told that, we have to do this panel on TTTS, and I saw the panelists, so I was quite intimidated on, how do we take this forward? Because there's so much of knowledge in each and every one of you that it's really a task to get all of it out in 1 hour. And that's the challenge that we have here. I would just request that, there are some questions regarding certain aspects of TTTS, but because all of you here really do these procedures, so please come out with your opinions so that it is, going forward, we do get a lot of insights. So we all know that TTTS is a serious complications that affects monochorionic pregnancy. And that happens because these twins share one single placenta. There are 3 different types of anastomosis, which is there in all monochorionic pregnancies. Artery to vein, which are deeper, superficial artery to artery, and superficial vein to vein. So TTTS occurs usually between 16 to 26 weeks of gestation, and occurs in up to 10 to 15% of monochorionic twins. So it's not a small matter. So it's a huge number. And with increasing conception by IVF, we are worried about, the increasing incidence of TTTS. So it's important that we be aware of it. So there are certain aspects of TTTS in which there is a robust diagnosis and evidence for treatment. But however, there are certain things which are still gray. like, what to do with stage 1, what to do with the early TTTS, the late TTTS, what actually are the outcomes. And as Mohit was saying in the beginning, with the increasing number of patients coming in, they need to know what options do they have. Then what are the optimal laser techniques, and can we prevent a preterm delivery in TTTS, and optimal timing and mode of delivery. So these are some of the aspects that we're going to cover in the next, I think 45 minutes that we have. So we begin with some of the very, very basic question that, because this goes a long way in improving the outcome of TTTS. So the first question would be, of course, to, talk about, because monochorionic twin is known to have complication, what is the monitoring protocol for monochorionic twins? And I would like to request Dr. Vatsala to take this question.
So, like as already said by Dr. Aparna, that monochorionic twins are at a higher risk of complications. So almost 30% of monochorionic twins will have some complication, and TTTS accounts for around 12%. So we need to do monitoring with serial ultrasounds to pick up these complications early, because untreated, there is a high uh, perinatal morbidity and mortality. So you can get some pointers right early in pregnancy when you're doing the 11 to 14 week scan. So again, here the chorionicity is most important, because all your management will depend on the chorionicity. And again, besides screening for trisomy, dating and labeling, we're also looking at some pointers which could, not very sensitive, but pointers that this pregnancy is likely to develop TTTS. These are a discordancy in the nuchal translucency of more than 20% between the two twins, or absent or reversed A wave in the ductus venosus in one of the twins, or even a discrepancy in the CRL. Although not very sensitive, but these are the pointers. Then after 16 weeks, we have to follow them after 14 weeks, we do a scan every 2 weeks to look for evidence of TTTS or for TAPS, that is twin anemia polycythemia syndrome. So the first thing we look at is the deepest vertical pocket, because that is the first criteria for diagnosing TTTS, oligopolysequence. And we also look at umbilical artery PI. We also look at the MCA PSV if you're screening for TAPS. So this is done at 16 weeks and 18 weeks. And then 20 weeks after you also do 4 weekly growth scans. So we do a growth scan, we would do a detailed anatomy scan, biometry, and again screening with umbilical artery PI, MCA PSV, and deepest vertical pocket for TTTS, and for TAPS and cervical length, because again there is increased risk of preterm birth. 22 weeks, again the same thing. So we screen for TTTS from 16 weeks to 28 to 30 weeks, because that is the time that it is likely to develop, and we continue screening for TAPS till 34 to 36 weeks, and every 4 weeks we are doing a growth scan. We would also like to do a fetal echo at 22 weeks, because again these monochorionic twins at a higher risk of cardiac defects. So basically that is how we keep monitoring throughout pregnancy for the complications. So for early detection of these complications.
Right. So thank you, ma'am. I think we just have to be aware of this entity, and we need to keep an eye for this. So thank you very much. Now, Dr. Chinmay, we all know that it's all about connections. So there are some good ones and not so good ones. So a little bit an overview of what is the understanding of the, pathogenic connections and protective connections, and how can we actually, it can help in our management.
So, in monochorionic twins, both the fetuses are connected to each other through the placenta, because they are sharing the placenta. So nature has designed one placenta to serve one fetus, and that's how it should be. But when they have to share the placenta, it's like eating from the same plate, to give a layman example, where we say that one fetus might be taking more and one fetus might be taking less. And the area of the placenta that is allocated to each fetus may not be exactly the same. So there could be an area-based discrepancy of how much each fetus is gaining from. And the vascular connections become very, very important. It's the key element which determines whether twin to twin transfusion will happen or not. So when twin to twin transfusion happens, there is some kind of a unusual connection, such that more blood goes towards one baby and less blood goes to one baby, even to the extent that you may think blood is going from one baby to the another baby, so that one becomes a donor and one becomes a recipient. So vascular connections are of 3 types. arterial, venous, or arteriovenous. So the arterial connections are expected to be somewhat better or good or protective, as you can say, because they have a similar kind of pressure on both the sides, and they kind of, whatever you mentioned in terms of protective and predictive connections. But venous connections also are similar in terms of pressure and their flows, but to a lesser extent. When it is arteriovenous connections, then the flow of blood is preferentially from the artery towards the vein, because the pressure is higher on one side and lesser on the other side. So whenever there are unbalanced arteriovenous anastomosis between two fetuses, there will be this condition called twin-to-twin transfusion. The side which will have more arterial connections will become the donor, and the side which will have more venous connections will become the recipient, such that the volume of blood flowing through the donor is lesser, the volume of blood flowing through the recipient is higher. And that leads to this whole pathophysiology of twin-to-twin transfusion syndrome.
Right. So very nicely put forward that it is basically an unequal connection of the arteriovenous, which is a unidirectional connection. So it has been seen that, the AA, which you said is protective, is to found to a much lesser extent in the TTS placentas as compared to the other one. So AA is protective, which is not there, and that also leads to discrepancy. So with this basic background in view, let us discuss some of the cases and see how we, manage some of them. So this was a lady who was a 24-year-old, second gravida, previous one abortion, spontaneous conception, DAMC twin, and she presented with at 19 weeks with a single Leica pocket of, one twin having 1.5, one twin having 9.4, with bladder was seen in both and with forward flow. So this was we know that, okay, so this was the situation where there was a polyhydramnios, there was an oligohydramnios, where the bladder was seen in both the twins, and there was no discordance at this time. So Dr. Vandana, before we go on, let's just, brush up the staging of TTTS. And because now I've mentioned that it is stage 1 TTTS, but let's just go back to the definition of stages of TTTS, Quintero staging.
Yeah. So for the staging of TTTS, we will follow the Quintero's classification. And for Quintero's, we will look at the Leica discrepancy first. So if the Leica discrepancy of one side is 2 and the poly is 10 and more if it is 20 weeks and above, and 8, 10 if it is less than 20 weeks, we will call it as stage 1 when there is a oligopoly sequence. Stage 2 will be when there is bladder which is seen in one and not seen in one. So bladder discrepancy will be taken as stage 2. Stage 3 will come when the Doppler discrepancies come in. So in the donor, you will see absent or reversal, and in the recipient, you will see ductus reversal. And in stage 4, there will be hydrops in one or both of them. And in stage 5, you will have either a death of one or both the twins. So this is a very simple Quintero's classification, and it is still being used for the management of Quintero for TTTS. But yes, it does not take into consideration cardiac at all. So then there are new classifications which have come up. But standard for management, I think we still follow this. But we also look at cardiac dysfunction, especially in stage 1, to decide.
Yeah. So interestingly, this was the first article which came in 1998 by Quintero. And so many times, I think if we look into the literature, people have really, sounded a death knell saying that we should move on, we should move forward. But somehow we keep going back to it because I think that's what the simplicity is. It somehow makes our lives simple. So now, we've till now we discussed something which we know, which is easy. Now we move on to the gray part. So now, Dr. Bijoy, what is a better criteria to diagnose polyhydramnios? Because, are we missing something? Are we overdiagnosing? So how much is too much? So what is the criteria for polyhydramnios? Do you believe in? What is the evidence? And what do you do? So 8 centimeter for all or more than 10 centimeter? Because Dr. Vandana said it is more than 10 centimeter for more than 20 weeks. So probably she follows it. So Bijoy, what do you think?
First of all, I prefer black and white than gray because when it comes to gray, there are a lot of people have different opinions. Now, for me, actually, all these patients are put on fortnightly surveillance, correct? Yes. So the diagnosis of stage 1 TTTS only increase, from my point of view, I do not do any intervention for stage 1 TTTS. So when I make the diagnosis of stage 1 TTTS, the only thing I'm going to do differently is I'm going to increase their surveillance. That's all. Okay. So for me, if I find a Liker discordance, and if it is greater than 8 in 1 and less than 2, as you have shown in your case, it is telling me that this baby is at risk for developing severe forms of TTTS. And I will not stop there. I will also look at the cardiac function to see if there are signs of volume overload. One of the reasons why Quintero fails is that it only looks at the end point of this AV anastomosis. It does not actually give us insights into how that disease is progressing or what is the stage. In stage 1 itself, there are various grades of stage 1 depending on the severity of cardiac dysfunction that is present. So if for me, if there is a Liker discordance of greater than 8 in one and less than 2 in the other, and that there are bladders are present in both, and you're looking at essentially stage 1, and if my intention is not to do any management and only increase surveillance, I would prefer to err on the side of caution, and I will go for 8 and 2 rather than waiting for 10 and sitting and saying that I'll call them back only after two weeks. I suspect that the reason why this difference is there in Europe is because there is this raging debate in Europe as to whether to offer treatment in stage 1 directly. And therefore, it makes sense to have that distinction, because if there is a definitive treatment that you're offering in stage 1, then it makes sense to have a diagnosis where you can go in and do treatment. For me, actually, stage 1, I still prefer not to touch these babies. Essentially, maybe because I'm afraid to cause more harm than benefit. But yeah, that's my take on it.
So Vijay says that, so if we diagnose, we are like, we want to intervene more, and that's why there's so much of discrepancy. Yes, Eurofetus was the first trial which talked about a more than 10 centimeter at 20 weeks, because if it is less than 20, maybe you want to intervene early. So there is this tendency to intervene early, and that is what is leading. But most of the criteria do talk about 8 centimeters, and it has been seen in a recent review that if you take only the criteria of MVP of more than 10, you would exclude 14.5% of the patient from actually getting a surgery, and you would, of which 60% would have an advanced stage TTTS. So there would be some merit in thinking like what you're saying, that everybody who's more than 8 centimeters, think about it. So that is something that we need to think. So expectant management up to 10 centimeter would probably delay management and is likely to improve, maybe not cause the improvement in survival. So, and also delay in laser surgery to achieve a more severe polyhydramnios may lead to hidden morbidity. So we might just take this point back that, okay, more than 8, we don't really have to wait for more than 10 to label it as TTTS and, institute a monitoring mechanism. So I think that's what is important, that on the suspicion of TTTS, you start your monitoring. Now, what happens in very early criteria prior to 18 weeks for TTTS? So very early gestation TTTS. Now there are people who say that we need to intervene early. So Manikandan, what is your view on this?
Early TTTS, yes, some people have proposed to keep 6 centimeters as the diagnostic criteria for the polysac. As Bijoy told, it's the same for me. 6 centimeters, okay, I know that something is going on. If the other one is stuck and this is 6 centimeter, I would increase my surveillance, but I wouldn't intervene till I'm sure that it is progressive. Essentially, Quintero stage 1 and 2 is only the same. It's just the degree of anuria progressing in the donor. So here also we allow it to become, for sure that it's a progressive disease. So I would still wait till it becomes 8 and then do, unless more outcome-based results are available to say that it really does improve survival rather than waiting. So at present 6, I will be cautious, but I wouldn't put the patient under the table, on the table.
Thank you. Thank you. So that was a very clear point, that we will wait. And if it is more, and we put the patient on surveillance. So the entire discussion around Liker is because that is the one definite criteria which establishes a diagnosis of TTTS if there is oligo and polyhydramnios. So the presence of polyhydramnios is important, and hence it is actually necessary to define the degree of polyhydramnios. So essentially, some would, they will not be, if we modify this criteria, some may not be managed as TTTS and therefore will not be offered prenatal intervention. So all the evidence currently says that, okay, we might need to keep the patients on greater surveillance. And this is the latest consensus protocol of 2024, which is the Delphi consensus. And they really talk about between 16 to 18 weeks of gestation. Basically, they should be managed expectantly. If, however, there are maternal symptoms, then we might consider intervention. But the crux is that we keep the patients on better surveillance on the suspicion of polyhydramnios. So again, like I was saying, there have been repeated articles saying that Quintero staging is not absolute. It is time to forget the Quintero staging. And imagine, this article actually came in 2007. And the Quintero staging came in 1998. So within 10 years of the Quintero staging, they said you should put it to rest. And now 20 years still after that, we are still at Quintero staging. So Vatsala ma'am, what are the limitations of staging and what are the other ways to prognosticate outcomes? And I would also like to know from all of the panelists that how much of the cardiac staging is being, cardiac evaluation is being to, tailor management. That is the question. So ma'am.
So there are some limitations to Quintero staging. First of all, like there may be atypical presentation, like you may have like sort of a donor with the like with a bladder which is visible but maybe having abnormal Doppler. So they may be atypical presentation like this. And also progression is not always stage wise. It is not that the stage 1 will progress to stage 2 or stage 3. It may jump from stage 1 to stage 3. Other thing is, if you use Quintero staging, then maybe it is not very good for early presentation, because if you look at the cutoff for maximum vertical pocket of 8 or 10, you have to see that if it is a 16 to 18 weeks, you may want to put the cutoff lower, not for intervening, but actually to put in a mechanism for monitoring these fetuses. And also looking, I mean, if you can look at an alternative way of monitoring, you can also use the Dopplers earlier, or you can even look at the cardiac function in these group if you want to do intervention. And so the alternatives have been to look at the cardiac function of the recipient twin. So people have used various sort of classification. So you have the CHOP classification, so in which you're looking at the basically the cardiac function in the recipient. You're looking at the Dopplers, peripheral Dopplers, and the cardiac functions. There are various parameters you're looking at. Then you have the Cincinnati classification, in which again, into the Quintero system, they have built in stage 3, like 3 A, B, C, depending on the cardiac function. They're looking at the ventricular hypertrophy, like the cardiac function, and also at AV regurgitation. So people have used different classification, but even if you look at these, they don't actually correlate very well. If you look at the CHOPS and then Cincinnati, and there is not much obviously like literature as to how these perform when you're actually using in clinical practice, as if whether it is really going to improve the perinatal outcome if you're using these for your management. So definitely these classifications are there in addition, but they may be helpful in stage 1, where if you have significant cardiac dysfunction in the recipient twin, you may want to intervene. And also in early stages of an early sort of early development of TTTS, like before 20 weeks.
Right. So thank you, ma'am. I think with the understanding of the pathophysiology of TTTS, we know that a lot of morbidity comes from ventricular dysfunction, cardiac dysfunction. So there have been various things as you propose. So I just want to know from the other panelists that, how much of weightage is being given to plan intervention, or do you use it to prognosticate?
Shall I go?
Yes,
Yeah.
yes, Vijay.
Okay, Aparna, one thing I want to say about the Quintero's classification is, although we say it's not useful or it is outdated, or there has been a debate on whether we should use it or not, and that there is no sequential progression, but as a clinician or a person who wants to decide to do treatment or not, it is a very good guide. It's not good as in terms of progression. But if I see a patient in stage 2 Quintero or stage 3 Quintero, I know immediately that I have to do something. I have to treat this patient. There is no doubt on that. Yes, it does not give you sequential progression, and sequential progression does not matter that much in TTTS, because once TTTS sets in, we are always going to follow them up on a weekly basis, or more frequently we will follow them up. That's one. And cardiac function is essential to understand how frequently we are going to follow up this patient, and also to understand whether our intervention is going to be beneficial for both of them. For example, we have seen, I'm sure all of you must have also seen, where you find a patient is in clinically stage 1 TTTS, but it already have severe cardiac dysfunction with everything going wrong from hypertrophy to regurgitation to even probably valvular stenosis. So in those conditions, we might not be able to get the same outcomes that you would get in a classical stage 1 TTTS. Therefore, cardiac function is imperative. We have to definitely do it in all cases. Yes, and Quintero staging does give us a clear guideline on whether we should intervene right now or not. So a combination of both is very, very useful. Quintero fails as a progressive tool, but that is where cardiac function does give us some insight in telling us that, okay, this is stage 1, but this is not your innocent stage 1 because the heart is looking really bad. And I'm sure that this is going to worsen in a few days. On the other hand, if I look at the cardiac function and I find that it is very good and it is in stage 1, I know this is a Quintero stage 1 that I'm not very worried about. So I guess both have their own significance and their importance.
Right. And as clinicians and providing for patient care, we do believe in the Quintero system, and I think we tailor our management according to that. So we definitely would do that. So I think that was what. So anybody wants to add something, or I should move? Manikandan, you want to add something?
No, I completely agree. It's a hemodynamic disease with an added layer of hormonal imbalance to tackle that hemodynamic imbalance. Ultimately, it is a cardiovascular thing. So, in all our patients, from the moment I suspect TTTS, my eyes will be on the recipient's heart also. And based on that, I would decide the frequency of surveillance and the urgency of intervention and the prognosis that I'm going to write post surgery.
Yeah. So thank you. And interestingly, it has been seen that, the progression is not really predicted by any of these factors. So yes, it does help us in, getting an idea, but still there is a lot of confusion around it. So now the question is that, okay, this patient came to us with TTTS stage 1. So what do you tell the patient? Like, how will it progress? What are the survival and, what are the outcomes of stage 1 TTTS? Because that is something that you are sitting on the fence to do or not to do. So Dr. Chinmay, what do you tell your patient, and, what are the chances?
Yeah. So when it is stage 1 TTTS, first and foremost, the counseling for any monochorionic pregnancy starts at the very beginning. So like when Vatsala ma'am told us the whole protocol for follow-up. So when we diagnose monochorionicity right in the first trimester, we tell them that every 2 weeks we will be seeing you. And these are the anticipated complications. So when the first sign of twin-to-twin transfusion is obvious and we know that this is stage 1, that's kind of a telling them that is it, we have arrived here. But like our colleagues have just said, it's not a sign of progression also, because in many cases stage 1 TTTS might remain just stage 1 TTTS and you may just keep following them up and it does not progress beyond that. About 30 to 40% of these patients will actually progress to subsequent stages, which again we cannot predict in the first go. But we know that a lot of it will remain just as it is and may not progress. The outcomes of stage 1 TTTS per se are always known to be best because this is the mildest form of twin-to-twin transfusion. And the finer details, like Bijoy and Manikandan said, would be dependent on what other problems are also coexisting. For example, how much load the hypovolemia is causing on the recipient's heart. So I would give them a very good prognosis at this stage. And even if you do not do anything, because in many cases you will not have to require to do anything and just keep them on serial follow-up, there is a good chance that 70 to 80% of both the babies might actually do well, or maybe at least 70% of both the babies. But if at all it progresses further, then depending on when it progresses, the outcomes will get further changed. So what you have written here is a pooled incidence of progression of about 27%. So that's fine. We generally advise like 30 to 40% of them. may progress into the next stage. Otherwise, most of them will remain at the same stage. The management, like you have mentioned here, as of now, I don't think we do that much of amnio reductions. We kind of tell them that if it gets worse, then the next stage will be intervention in the form of either the laser photocoagulation or whatever at that point the situation is. So the counseling in stage 1 is quite hopeful, and we tell them not to worry that much, although there's a lot of anxiety. The period of surveillance just changes because now we start seeing them a little more frequently than the traditional 2-weekly interval.
So stage 1 is a little, yes, Manikanda.
Can I add just the previous slide that Aparna showed? I would request if somebody is sitting on a stage 1 fetal medicine department, not to do an amnio reduction. If at all, when you go to a next level and you have to do an FLA, amnio reduction might actually reduce your chances of a successful FLA.
Yes, so this is agreed completely, and basically this data is coming from a systematic review where various methods have been tried on various things. But I think this is an important point that if we are planning laser at some point, it's better not to fiddle with the amniotic fluid and not do an amnio reduction. So I think that's a very valid point. So coming to this, so Dr. Chinmay also said that probably it is better to sit. Bijoy also said it is better to sit. But Dr. Vandana, do you think that there are certain situations in which you would want to intervene, or you would primarily want to intervene? So how do you, really to do or not to do laser in the stage 1?
So stage 1, I also believe in whatever Chinmay and Bijoy is saying and Manikandan, that we will just follow up. We will sit on that fence and keep monitoring it. We need to tell them these values, what you've given in the previous chart, that the expectant is almost as similar as laser. So we will wait till it reaches stage 2. But if there is a very cardiac dysfunction is there, so here I am using the Quintero and combining it with the CHOP score or by looking at cardiac dysfunction. So if I find the recipient is having cardiac overload, then probably I am more on the fence of maybe I will do a laser in them. So it is the cardiac dysfunction in the stage 1 only, the cardiac is important. Stage 2, 3, 4, so anyway, we are going to do a laser for most of them. It is in the stage 1 that we need to decide whether we do expectant or we do a laser in them. And I think cardiac dysfunction is what will decide. If it doesn't progress, I will just keep monitoring it maybe every week or even earlier than that.
Yeah. So thank you. And I think we are all on the same page regarding this. This was the RCT which talked about the stage intervention in stage 1, and they really found that intact survival between intervention and non-intervention was not really different. So they concluded that expectant management is a safe option in women without maternal symptoms, a long cervix, and those who have an access to fetoscopic center within 48 hours. And in these situations, 40% of the lasers may be avoided. So we need to have the fetal medicine centers need to individually discuss these cases according to the capabilities. And because there are no predictors of progression, and if she lives in some remote area where she cannot come back for monitoring, so those are the situations in which you can probably think of offering lasers in stage 1, or women who have too much of discomfort and a short cervix. So those are situations in which you would like to intervene. So this lady underwent, because she was a stage 1 TTTS, so she underwent scans weekly, bi-weekly. TTS actually resolved around 28 weeks. However, there was ADF of the donor twin at 32 weeks, for which a cesarean section was done, and the babies are doing well currently. So this was the stage 1 TTTS. We sat on it, monitored her very intensely, and then we delivered when we thought that the baby's one of the Dopplers was not okay. So this was about the stage 1 TTTS. Now we come to the stage 2 TTTS, which is more conventional. So this lady is 26-year-old, second gravida, para 1, live 1. She was referred at 23 weeks and 3 days with TTTS. Here we had the poly sequence. The bladder was seen in one, and bladder was not seen in the other. However, the Dopplers were forward in both the conditions. So now we have a stage 2 TTTS with a placenta which is posterior. So I think this lady did undergo a laser photo. I think this is something that all of us really, really wish that the placenta should be posterior, and so that we can do that. So now coming to the technicalities of it. So Manikandan, I would like to, little bit, in terms of the technique, and what would you like to tell us, and, little bit of a detail, because how do you approach, how do you identify, and, how do you coagulate?
So can I just share now?
Yes.
Okay. As far as the prerequisite is concerned, at least gross malformation should be excluded. Generally, it's not very easy to exclude all malformations, but grossly a limb missing or a big spina bifida or a HLHS, so those things should be anencephaly, those things should be excluded. Now, to plan the entry, what I teach is the latitude longitude method. So first you in the posterior placenta, find out the extent of the placenta, where there is a north pole, south pole, east and west. Then this is the donor. You find out where the donor is lying, and then you find the two cord insertions. So this is recipient and this is donor cord insertion, and then draw a line connecting the two cord insertion. Now then find the placental equator, which is the line that goes across the maximum diameter of the placenta parallel to this intercord line. Then along the donor meridian, you draw one line. Now the vascular equator is going to be parallel to this line somewhere. It can be close to the donor, or it can come in the middle of the donor and recipient cord based on the degree of discordance. So for example, in your case with a good donor umbilical flow, I'm expecting a discordance of about 10 to 15% for that case. So I would put it somewhere right in the middle, let's say somewhere here. And then where these two lines meet, that is the expected vascular equator and the placental equator. So this is where I would enter on the maternal abdomen. This would give me a good chance to hit the vascular equator perpendicularly. So my laser shots will go and hit the vessels perpendicularly, so I can coagulate. And also it will give me the best chance to reach the upper end and lower end, that is the north and south of the whole placenta. So I can travel both sides with the scope without getting tangential at any point. Now, if it's anterior placenta, we are all at the mercy of the patient only. Suppose this is the uterine wall and then this is the placenta. So I first find out where the donor cord insertion is, and then the recipient cord insertion will be hanging somewhere. I draw a line and extend it towards the recipient side as far away as possible. And where it is farthest from the recipient cord and where it is allowed by the maternal anatomy there without causing any harm, I enter there with the curved scope. So this is what I do. If you can't enter here, then find a point which is closest to that point. That's the entry point for anterior placenta. And regarding the technique of coagulation, let me just. I think I might have closed it off. Hold on. Technique of coagulation, I'll start from here. So this is, so first what I do is I do a quick sweep and find out the sentinel AV anastomosis. The sentinel AV anastomosis you'll always find as the biggest A from the donor and leads to a very big V or the biggest V for the recipient. And once you identify the sentinel, I start from there. So immediately we coagulate the artery of the donor. That's the one. So it stops the donor from becoming hypotensive. So we start from there and then we do all the donor AV. When you see a large AV, you go close, don't touch it, make the dot crisp, and then you start firing. If the vessel diameter is larger than the dot, the crisp dot that you make, then start firing from the sides and then fire towards the center. Then you usually fire a length of the artery and the vein that takes part in the anastomosis, not just a dot where it dips. In this case, as you can see, the placenta is very clean everywhere. So there are the participating anastomoses are few and far apart. So it's a clean placenta. Generally, I don't go for connecting the dots and damaging more of placenta. If it's a clean placenta, I go only to the anastomosis, do the anastomosis, and come out. But sometimes it will be very congested and crowded vessels. Then the technique of solemnization is used.
Okay.
So I'll stop the share here. Yeah. At the end, of course, amnio drainage is done so that we bring the maximum vertical pocket to about 6 to 7.
Yes. So thank you very much. So you talked about the insertion and identification. Of course, we have to look at that. And interestingly, what you told is what we wanted to discuss is which side of the anastomosis you coagulate first. And you said you do the donor artery first.
Yeah.
Because that will prevent the exsanguination and so that the baby, the outcomes are better. So yes, I mean, and this is what it is. So the placenta and of course identification. I know these things look really simple, but the arteries actually overlay the veins. So this is how you can really identify which is the AV and what is the VA. So we identify the donor, which side, which is the smaller side or maybe the stuck twin side. And when we start tracing the umbilical cord from there, we should be able to identify the arteries, and we do this side first. So that is an A and a V. And this donor vein to an artery is VA. So that is the message that Dr. Manikandan then also wanted to give, that it is first important to do the artery of the donor and then the vein. And of course, selective versus non-selective, what we have talked about is the selective coagulation. Earlier, all the vessels crossing the equator would be coagulated, but now we selectively coagulate the AV and the VA. So I think, so first we do the AV of the donor, then AV of the recipient, and then AA, and then VV. So this is the order which is suggested for the best outcomes, and it should be followed. Solomon technique, like you said, if it is a clean placenta, you don't do it. If it is not, so there are people who talk about both ways in the Solomon technique. It has been seen that, the survival of one twin, the odds ratio is increased. The recurrence, the odds ratio is decreased. However, the abruption increases in Solomon technique. So we need to choose the cases in which we need to do the Solomon techniques. So this was a little bit about the techniques. So Bijoy, how do you follow up your cases after doing a laser?
Before that, I just thought I'll just tell one point which might be useful for all of you, because you're all doing laser, and which has helped me a lot also. Exactly the same thing that Mani does, but I just do one thing. It may be a little bit more complicated in the sense that it's useful if you have a water-filled balloon or a condom that is filled with water, and you can map the placenta and actually make an artificial marking of the cord insertion and the boundaries. And when you're starting out, it usually helps you to understand what you're going to see when you go inside. And so that may help at least people who are starting out to do lasers, because sometimes when you go in, you can get lost. So if you know that this is how the placenta is and this is where the cord insertions are, it may be slightly a bit more helpful. So what we do is we make a dry run by looking at the like the balloon with the markings of the placenta and the cord insertion, and that gives us an idea as to where all these things are inside. Because sometimes when you enter in, everything might look suddenly hazy and you might be in a maze. And as Mani said, the first thing that we do is we look at the membrane, and once we identify the membrane and once we can see the membrane in its entire length, we know that we will probably get all the anastomosis, because any vessel that is exiting out from the membrane, or if any vessel is entering into that side of the fetus, we know that is the anastomosis that we should hunt down. So yeah, although it sounds easy, the difficult part is to identify these anastomosis, and to get a posterior placenta is I don't know, for some reason extremely rare these days, and most of the times we end up getting anterior placentas and we burn our fingers sometimes. So apart from that, If
No,
you,
and I completely agree with the thing that you're saying, because some people also do that with a balloon, filled up balloon.
yes,
Like
yes,
fill up a balloon with, just inflate a balloon and mark the placenta on it to get a
yeah.
better idea.
So you know exactly
Uh,
what you're entering and what you're entering. It's
yeah,
useful. But yeah, yes, Mani, go ahead.
Vijay, initially what I used to do, I used to draw in a piece of paper
Yeah.
the cord insertion and know what is expected, and then we used to stick it inside a pot
Okay.
on the undersurface of the pot and then rotate it wherever you think is the placenta. So it's a good thing. Actually, it's a good idea to do a dry run at the beginning so that you know where to enter and how to move about.
Yes, yes. Yeah, and as far as the procedure is concerned and what you do post follow up, I think the couple of things. One, we are reversing the hemodynamics, so we are changing the volume shift that is happening from one fetus to the other. So the first evidence of the volume shift coming back to the donor would be the presence of the bladder. So it's wrong to think that the liquor will be completely normal in the first 24 hours. It may take more than that for the liquor to even begin to normalize. So the first sign of volume shift happening into the normal level is when you see a bladder that is going to be visible. It may take around 24 hours. So don't do the laser in the morning and then come back in the evening and start hunting for the bladder and feel sorry about it. Give it 24 hours and look at the bladder the next day. So that's the first thing. And the second thing is, if you find normalization of liquor immediately after the procedure, understand that most likely you must have created a septostomy, you must have perforated the membrane, and that's why liquor is becoming normal on either side. It's not a sign of procedural success. That is the second thing. Third thing, you should not expect the cardiac function of the recipient to resolve itself immediately. It's going to take some time. But on the other hand, on the donor, you may find signs of volume overload, because that baby was losing blood up till now. And then suddenly all that blood is going to come back into the donor. And one of the signs that we have seen is a pansystolic tricuspid regurgitation that develops within the first 24 hours. And that's not something that we need to be worried about. You can see transient TR in the
Camera.
in the donor, because now the donor is getting all of its blood to its own side. So that's the first thing that we see in the first 24 to 48 hours. And once we see the bladder, it's actually a very relieving feeling to see the bladder, and it's probably we are all celebrating at that point of time to know that this procedure was a success. And then we are worried about the next things that can happen in the next few days. That's the patient going into preterm labor. Although we do put them on prophylaxis for around 48 hours, after that, the next biggest worry is whether she's going to go into preterm labor or preterm contractions. And we monitor them on a weekly basis. We look at the cervical length. And sometimes, if the course was very short while the procedure was going on, we may even put a cerclage as well. So
I'll
dependent
take that
on
cerclage question in
Sorry?
a bit.
Okay, sorry,
I'll
I'm
take
not
that
going there.
cerclage question
Yeah,
in a bit.
okay. Then I'm not going there. So then after that, we follow them up on a 4 weekly basis. Then what we're worried about is whether we have caused any cerebral damage. So we're looking at intracranial findings and things like cerebral findings essentially 4 weeks later on. And of course, the most dreaded complication of twin anemia polycythemia sequence, and also persistent TTTS, where you have not corrected the situation completely, and you're left behind with a few anastomosis, which would probably continue to transfuse blood from the donor to the recipient. Yeah, these are the things that we look
Right.
at.
Just a point to add, sorry. One of the earliest changes that actually we see is a collapse or a relaxed recipient bladder. So just before the procedure, you will see a tense bladder, but then it's a subjective thing. So if you carefully see in all cases, you can see that the bladder relaxes. It becomes the normal shape, not a sphere that will be there before the procedure in the recipient. And like Bijoy told, donor will show signs of sudden volume overload. You can get TR, you can get donor cardiac, squeeze little bit subjectively less, and also some degree of edema in the neck, nuchal edema, subcutaneous edema. All are good signs actually.
Yes, the only time when we are happy when we see it.
Correct.
Right, I agree. So this lady, she responded well and she was followed up. And so basically the point that you came put up is like, do you routinely do MRIs, laser, post-laser?
No, we don't. We just do follow them up with transvaginal ultrasound and look at the brains, and we leave it at that unless we find there is something suspicious on ultrasound. Because first of all, we don't have the expertise for doing MRI at a later gestation, especially for twins. I wouldn't probably advise that. But if yes, we find something on ultrasound, we see ventriculomegaly and things like that, then maybe we may advise for an MRI. But otherwise, no.
So it has
Yeah.
been seen that most of whatever changes you're there are going to be detected on an ultrasound, and general prevalence is around 2 to 6%. But interestingly, it has also been seen that, it may or may not be because of laser. It may be a process of the monochorionic
Yes.
pathophysiology itself. So it's
Yes.
very difficult to see. And of course, if there is a co-twin demise, then possibly you would like to look at the MRI. So
Here
now,
I wanted to add something.
Yes.
When we were talking about TTTS staging and cardiac function assessment, I wanted to tell, but I forgot that we have to definitely look into the brain of the recipient, do a detailed neurosonography before procedure, establish that that's okay pre-procedure, then only we should go.
Yeah, I think that's an important point, and that whatever was the baseline condition, and did the procedure cause the damage? So I think that's something that we really need to look into. So Dr. Chinmay, in terms of, so we've talked about the procedure follow-up. So in terms of maternal complications and, what is the real problem with FLS?
So when intervention is undertaken in twin-to-twin transfusion, there is already overdistension of the uterus. And then you're putting in an instrument in there and doing a procedure. And sometimes it requires a kind of manipulation that's happening there. So one of the common complications that we have post this is just rupture of membranes, leaking from the sac from where you've actually entered, because usually that is the polyhydramniotic sac. And that is initially a very dreaded complication, and we start worrying a lot. But in some cases, it actually may subside on its own. If it does not, then that is another cause of worry. But it may just be useful to wait for some time, not panic at the first gush of liquor there. Because if the cervix is long enough, and this is usually a high leak because you've intervened somewhere above and not just on the internal loss. So after some time, and you need to give them antibiotics and wait and watch. I personally don't have much experience with the amnio sealants, although there's a lot of discussion happening now, and maybe Mani or Vijay could, Dr. Vandana could chip in if there is any role of doing an amniotic fluid sealing with all these sealants that have been talked about. But we've never done that. We just wait and watch, and if the leaking subsides, then the pregnancy continues as it should. Abruption of the placenta is a theoretical possibility. Touch wood, we've not had such a complication as such, but in theory, it is possible, especially in cases where initially we used to do amnio drainage or something like that, when there is a sudden decompression of the gravid uterus. But that also seems to be not so much of a practical problem. The one practical problem which we are all very worried about is sometimes the cervix is already short by the time she comes for the treatment. And it is a very big dilemma of whether to put in a cerclage first or do the procedure first. Putting in a cerclage first is a little difficult because you don't know whether the procedure itself is going to succeed or not. But once you do the procedure, you're increasing the complexity of the cervical incompetence. So like Bijoy said, we wait for some time after the procedure is successful and the woman is like stable, then probably we do a cerclage if the cervix is less than 20. If it is more than 20, we just wait. We don't do anything. We give her progesterone and wait and watch and try and pull the pregnancy to as much as possible. STDs have not helped us, but yes, we have used cerclage post-procedure in many cases. Evidence versus practice, well, that's all gray zones because the whole
So I would just like to
cohort.
know from the other panelists also whether they routinely put cerclage in a short cervix after the procedure or not.
Okay, in a short cervix, first I do the procedure. Once we have removed the fluid, and then we do a transvaginal scan in the OT itself. So if it's a short cervix, I usually book a OT and do. And then if it's still short, and if there is any inkling of internal loss not showing proper I mean, it's not closed properly. It shows a bit of funneling. Then definitely in the same sitting, I do a cerclage. I don't wait. I proceed with the cerclage in the same sitting. If it's not short, then definitely no cerclage.
Right.
Another complication that I wanted to inform is the complication of chorioamnionitis. And for me, it's mostly host factor, I feel, because I do fetoscopy in my clean procedure room, that is, as a OPD basis, I do and send. Many patients go well, no chorioamnionitis, but when I do book a OT and do, sometimes chorioamnionitis comes. So I think one of the important pre-procedure workup that we have started including is to do a high vaginal swab and a urine culture, and in addition to taking all the aseptic precautions.
Yeah, I think that's for any procedure that we are doing. So that's something that can be considered. Dr. Vandana, would you like to? What is your opinion on this? And do you put any other interventions?
No, I think one is there is an over distension which causes the short cervix. So it is not technically a cervical incompetence. It is just the pressure of the TTTS and the polyhydramnios. So as a routine, we would not put a cerclage, but we will reduce down the fluid from that sac, recipient sac, which may be again a method of prevention of preterm labor, that you're reducing the distension from that baby. And then I will also look at the cervix at the same time. So if I find funneling even after removing the fluid after the procedure, then at the same procedure as what Manikandan said, I don't want the patient to go through another anesthesia and do that. So we will put, if it is funneled and it is short, then we'll do. But otherwise, as a routine, 2 centimeters and above, I will not put a cerclage.
Vatsala ma'am, would you like to add something here?
Who? Sorry, Aparna?
No, I was just asking Vatsala ma'am if she wants to add something here.
So we also do that. If the cervical length is less than 25 mm, then we put, and the procedure is successful, then we put the cerclage in the same sitting. So we take a cutoff of around 25 mm.
Right. So basically, there was this meta-analysis which looked into the role of cerclage and other interventions. So it has been seen that, even with a short cervix, cerclage really does not improve the prognosis too much. And in fact, the procedure to delivery interval was smaller in patients who did undergo cerclage, but the reason being possibly that they already had a very short cervix. So it's possibly the disease process, and even if you had not put the cerclage, those women would have undergone. So currently, like they say that this is the Achilles heel, preterm delivery, PPROM. Even if we are celebrating the success, the technical success of a process, the next day morning the patient goes into labor or she leaks, then all our happiness really goes away. But I think yes, and none of the interventions have really worked so far. So that's really unfortunate regarding that. Now, we discussed a part about recurrence of
So
TTTS.
can I just ask here, my colleagues, what is their protocol for tocolysis? Is it with the procedure?
Okay, we start indomethacin 25 milligrams the previous evening and give it 6 hourly, and then we continue it for 72 hours totally. And if it is more than 24 weeks, then we also add nifedipine. So mostly it will be less than 24 weeks, so indomethacin.
So Manikandan, you use oral indomethacin.
Oral, madam.
Oral.
Rectal not available freely, that's what. And if she starts contracting, then magnesium sulfate.
Right.
5 grams in 50 ml, 10 ml per hour over 5 hours.
Right. So we use nifedipine in most of the cases. We are using nifedipine there.
We also use the same nifedipine, but we use both nifedipine and indomethacin.
Indomethacin.
Sometimes you go all out with whatever you have to prevent preterm labor. So whatever we can give, we give. Yeah, that's it.
So, Vatsala ma'am, in case of, say, overall, we talked about outcomes in stage 1 TTTS, but in terms of the stratified stage-wise outcomes in the more common and intervention patients, 2 to 4. So, what would you tell the patient and how do you go about it?
So after the successful laser procedure, I mean, overall, we can say like survival of one twin is up to 90%, and survival of both twins will be somewhere around 65 to 67, 68%. If you go stage wise, I mean, as the stage increases, the survival for both both the twins would be less. So if you take stage 1, then the survival of one twin may be as high as 90%, and both the twins may be something around 70%. And if you go down to stage 4, then it may be like something like 50% for both, and two twins and single twin maybe 70% or so.
Right. So I think this was the 2020 evidence which said what you have mentioned here, that one twin survival in stage 1 can go up to 90%, and but both twins is up to 70%. And in the stage 2, again, it is almost equal to that. And this brings us to what Dr. Manikandan said in the beginning, that actually stage 1 and stage 2 are clubbed together. And there's not much of difference between the two stages. And stage 3 and stage 4 are mostly kind of similar. So the outcomes are can be categorized according to these, and basically not much of a difference between stage 2, 1 and 2. But what really makes a difference is whether it is, say, in case it's a stage 4 and recipient disease, then the outcome comes down to almost 45%. So the survival is very less in case of, stage 3 and stage 4, and especially the stage 3 donor and stage 4 recipient. So I think those are the things that really make a big difference in terms of outcomes, and that is what we really need to note. And for counseling also, depending on what is the donor disease, what is the recipient disease, it really makes a difference.
Aparna, just a point there. Stage 3 donor is sort of a different disease according to me. It's really not just a hemodynamic problem, because in stage 3 donor, most often than not, it will be a small endowment of placenta for the donor.
Yeah,
And
exactly.
we are looking at a slightly heterogeneous group there.
Yeah.
So stage 3 recipient, I'll be happy to laser, but donor, I'll be a little bit wary.
Yes, yes, I agree, and that is what has been seen in the literature also, that the stage 3 donor has the worst prognosis. So because it is associated with SFGR, and I think that's what we'll quickly discuss. We have around, say, 10 to 15 minutes more. So this lady, typically posterior placenta stage 2, had a good outcome, and 2075 to 2200 grams, and she had a vaginal delivery at 36 weeks. So coming to the next case, I'll just quickly ask this question, is because now there is a lot of controversy around it, like how far will you really push it, the laser? So this lady actually came to us with DAMC twin at 27 weeks and 4 days with stage 3 TTTS. So would you do a laser? Would you not do a laser? So that is the question here. So Dr. Vandana?
So we would do laser till 26 weeks. And beyond that, yes, there are some studies which are saying it may help. But I would more towards maybe give steroid myself and deliver her, because she's already 27 plus 4 weeks, stage 3 almost. So I would more error on the side of just giving her delivery cesarean section with steroid and Maxel. The risk is so high that while doing the laser, they could cause more problem than not. So here, because she's almost 28 weeks and I have an NICU which can work better, I might want to deliver her rather than do
Any
laser.
other difference of opinion there?
No, I think when we look at 28 week survival, we are looking at around 50% survival for the pregnancy. I think the honest answer here is, if I am doing like maybe 4 lasers per month and I'm an expert at laser, I will definitely do laser at 27 plus 6 weeks.
Yes.
And the reason I'm not doing it at 27 plus 6 weeks is because, from my point of view, from what I'm doing like maybe we are seeing one laser maybe in once in 2 months. So I don't have that much confidence in myself to say that I can go in and do a better job than the NICU. But if I'm doing lasers very frequently and I'm an expert at laser, that I can just go in and do it like how the person in that paper, Kurt Heckner, does. He does it like, for 5 minutes, he does it as if he's doing an amniocentesis and comes back and sits and sees the rest of his patients. I would definitely think that laser is a better option than risking that baby in the NICU. Because you're looking at a lot of other things, survival, long-term morbidity, so many things, and the future outcomes of that child. The problem right now for all of us, I'm talking about centers that don't have that much volumes, is that the thing is there are multiple centers, and these cases are being divided across, and we are not sharing our expertise
Yeah.
that much, so that all of us will be able to provide the same kind of care. So if we reach a stage where we are able to pool our resources and find one center per state or something, where all of us pool our lasers and do it together, I think we will reach a point where we will be able to offer lasers with good outcomes at 27+6 or 27+8.
Agreed. I think that.
But
now
also
that
technically, how easy will it be? It's a 27-week fetus
yeah, I
with
was just
stage 3 TTCS. So, I mean, the technical considerations also have to be taken into account here.
I'm not talking
I was
about
about to
baby.
tell my policy, and then Vijay has told these words, so it's a bit difficult now to tell. Anyway, I
No,
will
go
tell.
ahead. No, you can tell your policy.
So,
No
so our
problem.
policy is between 26 and 28 weeks. We counsel that we will put the scope in, and then we will assess the anatomy. If feasible, and if it's a straightforward case, we will proceed with laser. Otherwise, we'll do an amnio drainage and come out and deliver at the next opportunity that we have. So prolong as much as possible and do. Once you have told that only Kurt Hegner can do that, then it's very difficult for me to
No.
make a
No,
policy.
you actually agreed with what I was saying. I was saying is that we have not reached a point where we can confidently say that we will be able to do it. See, we are
Yeah.
going in, we are testing the waters, and if we find that the waters are good, we are planning to take the plunge and swim.
Correct.
But
Yeah.
we may reach a point where we don't need to test the waters, where we feel that okay, this is the least. It's like we talked once. It should be like doing a cesarean section. And
Yeah.
when we are so confident about doing a cesarean section, we don't even think twice. No matter what the case is, we know we can do it. The same thing should happen for TTTS in laser. And when we reach that stage, maybe 10 years from now, we will all be sitting here and saying, why would you want to wait? That's exactly what I'm saying.
Yes.
My
So I
consideration
think
is the technical aspect of it, because the
yes.
size of the uterus is bigger, the size of the vessels are bigger, the size of your instruments are the same. And you are planning to reach a distant.
Yes.
More than the size of the uterus or the vessels, it's your accessibility, because in a posterior placenta, the baby will lie down flat on the anastomosis and you can't do much about it. You won't know whether you can fully treat or fully explore or not. And in an anterior placenta, whether the nearmost anastomosis you will be able to shoot or not. So
Yeah, I
whether
think
you have a clean field or not is the question.
so I think that is where the guidelines also are there, that you might want to try it, but it may be technically feasible or not. It is, and actually there are papers which describe what Mani also has just said, that you go in, see if it is feasible or not. If it is feasible, do it. Otherwise, do amnio reduction and come out. So I think that's something. And interestingly, in this case, we did do a laser. However,
Very
she
good.
ended up
They are the
having.
cut hedges of our country. They have 2 lasers per week.
But we still, I mean, that was a difficult case, and she leaked after 3 weeks. So she did land up in, and I here I would like to also put across that these are the guidelines which have been published by the Society of Fetal Medicine to perform laser photocoagulation. I think following protocols and understanding all of these facts which are now discussed are given. So this lady actually, like I said, delivered after 31 weeks, and the babies are currently doing well. Like day before yesterday, I called her, and both the babies are doing quite well.
Excellent.
So, and in this, so just a few more questions. That amnio reduction we have discussed, late TTTS, if the patient is asymptomatic and we want to prolong, so we just skip that. And we come to 2 last scenarios. So this case scenario are 3 cases of TTTS where you see that there is discordance, 31%, 24%, 35% discordance is there. So this is TTTS with SFGR. And so just wanted to know, ma'am, Dr. Vatsala, ma'am, I'll just ask you also, because these are all the cases that we have managed together. So what is your idea on all of these things with SFGR? What are the management options, and how do they fare with respect to the stage 2 TTTS without SFGR?
Should I go first or Dr. Manikandan?
Ma'am, Dr. Vatsala.
Ma'am, you please go.
So, like what we have seen, like, if you have associated SFGR, we find that the outcome is worse compared to if there is no SFGR. Definitely, like the single survival of single or both twins is maybe 5-10% lower compared to if you do not have SFGR, and the risk of losing the smaller twin is also higher. Probably some anastomosis, it's like some flow from the bigger twin is supporting the growth of the smaller twin. So once you cut off that anastomosis, also like the risk of losing the smaller twin is higher.
Yeah. So the prognosis is more morbid in these cases. So Dr. Mani, you want to add something?
Yes, if you can go back on your slide. So I focus on what is the that biometry. Yeah. So in the top left, A and B is 353 grams. I'm okay. I will offer. And in the second one, it's 230 grams. There, I'm a bit concerned, but I will still offer. And in the third one, definitely I'll offer. It's 888 grams. Definitely I'll offer. So I will look at that absolute value. And after the laser, it may have a few more weeks to go and whether it will reach a salvageable threshold. That is number one. Secondly, after we go inside, I will have a look at the territorial endowment for the donor or the smaller one. I'm sorry, smaller one. So then I will decide how much of territory that should be let's say, I'm not getting the correct word, encroach when we do a laser from donor. So I will allow a lot of territory for the donor and keep my line on the recipient side mostly. So I'll try to spare more of donor in complex anastomosis. So anastomosis can be simple or complex. When you get 2 or 3 together, then we give away the recipient rather than the donor side. But if you have FGR of the recipient, then I would straight away go for selective feticide. That's not going to survive at all after a laser. So recipient FGR, no. Rest all, I would give a try.
Right. So
Just,
yes, I mean, yeah.
No, just one thing about SFGR and TTTS. Now, if you find if it is basically if one baby is small, and if you find that it is if there is a Doppler abnormality, as we already discussed in the previous slide, that if it is a stage 3 with SFGR with an abnormality in Doppler, I just want to get all of your opinion. Would you prefer to do a feticide rather than going in for laser? Because if you're finding that one baby is small, there is a discordance, and it is SFGR, say type 2, and do you
That's
want to
my
go
next
in?
question. Just give me 1 minute. Let me
Oh,
finish
sorry.
with.
Sorry.
So yes, I mean, so what has been seen is that this was a 2023 meta-analysis, which says that, the overall fetal loss after laser surgery, neurological morbidity is more in TTTS, which is complicated by SFGR. So yes, the outcomes are not very great, but if there is no Doppler abnormality, then possibly, like you said, that we could think of doing a laser. Having told the patient that, okay, this is the situation and we are going to do this, but the outcomes may be not as great as a TTTS. And with that, we come to the last case here. That is DAMC twin TTTS at 24 weeks. And here the donor, there is a hydrops in the recipient. And the donor flows are also less. So this is basically a stage 4 TTTS with Doppler abnormalities with hydrops. So again, maybe we can deal these two questions that you've asked together. That what are the management options? And here, would you like to offer SFR, selective fetal reduction, or versus laser? So Vatsala ma'am.
I think we need to counsel the couple what they want and give them the survival rates, but then maybe I would go for, selective reduction.
Right.
If it's
Which one?
recipient, then
Which one
I would
would you-
always go for laser because I know laser can reverse the pathophysiology of the recipient unless, of course, the recipient is in irreversible cardiomyopathy, which we cannot always say. For the donor, if the donor is like very small, it can't reach the threshold to be salvaged, then that option will be considered in exceptional cases. But recipient showing volume overload and therefore the DV is reversing or therefore the cardiac squeeze is a bit less, I would always give it a chance.
Right. So other people, Vandana, Chinmay, Bijoy, what do you think?
For me, the SFGR, if you're looking at SFGR, and as Mani said, if it's the donor baby and the baby is small and there is it's SFGR type 2 or type 3, let's say type 2 to avoid any confusion. And then you know that baby is not going to survive even if you laser it out because its share is going to be extremely less and it will not survive. So for me, in that case is very clear. Now, if it is the recipient that is having high drops and is showing signs of cardiac compromise, then I always give the patient the option that they have an easier option of selective feticide or going in for laser. And again, I'm always looking at the placenta also. If it's a posterior placenta, maybe my counseling will be more in favor of doing a laser because
Yes.
I'm more sure of the slightly more sure, I can't say more sure, slightly more sure of being more successful. But if it's an anterior placenta and I'm seeing high drops and tricuspid regurgitation, MR, pulmonary stenosis and atresia and all those things in the recipient, then probably I will not risk a difficult procedure and probably offer them the easier option of now, having said that, I should give a case here, which me and Mani both managed. I gave the option of fetal reduction. Mani gave the option of laser, and those babies survived. So it's a call. It's a very difficult decision to take, but I took the decision of reduction because I felt that that baby might not survive, and I'm sure Mani might also remember the case.
Yeah, I remember.
And they went.
She kept delaying because she was shunting between you and me.
Yeah, but I think it worked in their favor, and both they got both the babies. But I think it's a very difficult decision to take, and in retrospect, we can always think that this is probably better. But from my side, I would have probably not ventured to do it. But now, since we have had a successful case, next time probably I may venture in that direction. But again, if it's an anterior placenta, I will be a little bit doubtful on my success with a very bad stage 4.
Yeah.
Anterior placenta also, if you are able to, my approach is, as I had showed you, if I am able to enter where I wanted to enter, if that access is there, I would go in. I wouldn't hesitate. With that access, you should be able to, cover entirely. You wouldn't miss it. Only the problem comes when you are not able to enter like that and you have to compromise the entry.
Right. So I think the whole situation is about, how confident we are in doing that technique in terms of the placenta or the accessibility. So if we are quite confident about it, placenta is posterior, accessibility is good, then possibly we can give it a chance. But yes, I mean, that's something because again, just to come back to this slide, that stage 4 recipient again has something between 50% survival to 60% survival post laser. And donor, of course, has even a lesser survival in terms of post-laser stage 3 donor. So that is something that we must keep in mind while counseling our patients that, yes, individually, yes, I mean, depends on our expertise, but this is what the evidence states. And we must, really inform the patient about it. So we know that the
If the
vaso-occlusive
discrepancy is more than 40% or 50%, I think we are on the side of selective feticide.
Can I ask Aparna that if there is a hydrops of the recipient, then which feticide will you do? Will you do of the SFGR baby or the hydropic baby with cardiac dysfunction?
Yeah,
You
so we generally,
cannot
This
do
is a difficult call.
yeah.
If you have to do a reduction and the recipient is already hydropic with a cardiac dysfunction, while the IUGR baby is okay for.
Yeah, so we do for us, we do the hydropic baby, yes.
Hydropic baby, no? Yeah.
Yes. So in our experience, we have looked into the various RFAs or selective fetal reduction, which we did. And in a series of 100 cases, we did 49 cases for TTTS, and of which 77% had live births. So there are various indications for doing it, but TTTS approached 77%. And I would again like to remind that there are fetal therapy guidelines available for radiofrequency ablation, and I think anybody who's interested must look into it. And this lady, currently at 1 year, the baby was, because it was the hydropic baby that we reduced, the smaller baby was growth restricted 1415 grams, but went home well, and now at 1 year old and doing well. So the last thing is about how do you deliver and the timing of delivery, Dr. Chinmay?
Yeah, so we once we do the procedure, see, like you have written there, the evidence says you deliver around 34 weeks, but really we don't stick to that, because if everything is going fine and we have a basis of monitoring and the patient will be on constant follow-up, then we try to take it as much as possible towards 37 weeks.
Right.
Once we reach 37 weeks, we deliver. And most of these patients, after having undergone all these interventions in the antenatal period, they opt for a cesarean section. And we have so far done cesarean sections, unless they've come in labor and, expelled
You
the
did not manage to
babies.
do a cesarean section.
Yes, unless it's a failed cesarean section.
Could not reach
So
to.
the target is to take them to 37. Having said that, there is a high risk of preterm labor, and they do come in preterm labor. So when they come in preterm labor, we do that. But I have a problem with that guideline which says that once the procedure is done, you have to deliver them at 34 weeks, because especially in cases where we do radiofrequency ablation and there's only a single baby which is now continuing and there is no complication otherwise, I don't see any reason why we should deliver at 34 weeks.
These are the guidelines, and they say that if there is no post-laser complications, you can take up to 36 to 39 weeks.
That has started coming now, because
Yes.
till a few years back, I remember somebody presented a paper and the judge actually got annoyed with her that why did you pull the patients to 36, 37 weeks.
Take them to
So we do
If
try
it
and take
is,
them to 30.
if it's a laser and both fetuses are going, we feel safe to deliver between 34 and 35 and not go beyond that, because during my fellowship we have had certain bad outcomes, and we couldn't come to terms with that, and there was no explanation also why would double demise or a single demise happen after 34-35 weeks. Anyway, so our protocol here is to offer at 34 weeks. We give steroid and deliver by 34 weeks. And at 34, you don't expect them to succeed with induction of labor. So mostly it end up in cesarean.
Cesarean section. Yeah. So I think we've just.
Vijay, 34 or 37?
The baby is out in the NICU by 35.
Yeah, thanks.
I think
The
Chinmay was speaking about
primary
RFA.
reason here is basically we are very afraid to lose these babies after doing a successful procedure,
True.
and it's probably going to haunt you for the rest of your life, and you thinking, why
No,
didn't I
but
take this
especially
baby?
in cases of
No, but
the
what
selective fetal reductions,
Selective
where
fetal reduction, yeah, you treat
we
them
go
as
to
singleton.
37.
no,
Yeah,
but
we treat them.
what Chinmay said is absolutely right about singleton pregnancy,
Correct.
singleton survivor. There's no doubt on that.
Yeah.
Talking about those cases that are remaining as twins, and even though we know that we have dichorionized the placenta, deep down we know that probably there must be that small
Deep
anastomosis that's
anastomosis,
still
yeah.
left behind, and we will get a double intrauterine fetal demise. So even though we are very confident about the other things, I would prefer to take these babies out once they cross 34. But singleton, I
Yeah.
definitely agree.
Agreed.
There is no risk in singleton. I don't think there is any need to take them out at 34. But twins, yes.
Correct.
Yeah.
Twins, I would not risk it.
So the last thing is about long-term outcomes, and we do know that there is an overall incidence of neurodevelopmental impairment, and I will not probably want to dwell upon it because we've really exceeded our time. So we just, to conclude, stage 1, no tolerable symptoms, maybe expected management, debilitating symptoms, can consider laser. Amnioreduction after fetoscopy is something which will immediately relieve the symptoms, and we also do it routinely. Biophysical profile monitoring of 30 weeks onwards, and delivery 36 to 37 weeks, depending on what the condition of the baby is. So again, 2 to 4 TTTS, 16 to 26 weeks, laser ablation, amnioreduction more than 26 weeks, like we discussed, depends on the technical feasibility. And the role of selective feticide is when you have, advanced stage 4 or, life-threatening anomaly, failed laser ablation, TAPS, or recurrent. So 9% have reported to have some degree of long-term neurodevelopmental outcome. So these are the guidelines related to TTTS, which are available on the SFM website, and all of them can be accessed freely. And every unit must have their own protocols in place for the patient information leaflet. so that the patients are informed according to the successes which the unit has had in the past and based on your experience. So with that, we come to the end of the panel, and SFM, this TTTS Awareness Month in the month of December. What can we do really is create awareness among the care providers, as we discussed from the very beginning, that please monitor the monochorionic twins very carefully, create awareness among patients, and what Bijoy was saying is create a fetal therapy network to provide ease of access to therapy. I think a lot of times women are diagnosed, but by the time they reach, they have excessive polyhydramnios. And we can have an SFM web page on TTTS. And of course, the ultimate need is to have support group of patients who've gone through this, who can actually provide help and support to the other members. So thank you very much. And I thank all the panelists for their extremely interesting and very, very, meaningful inputs. So thank you very much. And
Thank you,
that's
Dr. Aparna.
Thank you.
Thank you.
Very nice discussion, Aparna. Good cases.
Thank you for the nice cases and everything.
Yeah. Thank you, Aparna Doctor, and all the panelists. Thank you, Ashok Khurana sir.
A pleasure, my dear. It's, of course, I would move on to actually formally thanking each one of you for being here. When we founded the Society of Fetal Medicine 13 years ago, I could have never believed that in less than a decade and a half, I would actually be seeing a program like this without any foreign representation on my screen. Today, we have excellent experts who are doing this work. We have series that are larger than 100. We've published series that have been admired the world over, and we have rapidly emerging expertise. What is also wonderful is that before everybody started doing what they felt like, we have guidelines in place which have been written by ourselves without interference from anybody else. That our guidelines still hold true after all this time. And I think that is absolutely fantastic. So you can imagine for somebody like me, what a great moment it is. And for the entire Society of Fetal Medicine, all our 5,000 members, and all those who are not 5,000 members, that 300 people actually tuned in, curious minds, curious to learn and curious to know. I think this is truly the biggest diamond we have in our cap in recent times. And I congratulate Dr. Aparna Sharma for taking us through this, and for panelists for enlightening us through this, and for the attendees for actually being here. It's really amazing, really an amazing experience. We've also had only one question in the chat box, and that was on the use of amnioceal, and we've already discussed that. The only thing that I would like to add is one little thing which I feel that we should understand a little more carefully, and this is not for the panelists, but really for our attendees, is how we look at a meta-analysis. We tend to believe that every word of a meta-analysis is true and a logical conclusion, and that may not necessarily be true. When we do meta-analysis, we don't find too many that fit, and sometimes some authors would fit in a fair degree of inhomogeneous data that comes in without the same type of analysis. So please do take meta-analysis with a pinch of salt and make sure that a guideline like today's webinar will be on YouTube for all of us to follow, which is actual experience with actual hands in real-time India. And truly, I think it's an inspiration that during World TTTS Awareness Month and just a week after World TTTS Day, we've achieved something like this. A very, very special thanks to everyone who was on the faculty today, and a very special thanks for everyone else who joined us. Thank you very much. Congratulations and good night.
Thank you, sir.
Thank you so much, sir. Thank you.
Thank you, sir. Good night.
Thank you and good night.
Good night.